Dear colleagues, this talk is about the use of botulinum toxin A in refractory non-neurogenic overactive bladder. I have no disclosures. Currently, two types of botulinum toxin A are used for the treatment of overactive bladder: onabotulinum toxin A and abobotulinum toxin A. The conversion rate of abobotulinum toxin A versus onabotulinum toxin A is 3:1. Overactive bladder is the most common voiding dysfunction in pediatric population. The management consists of urotherapy, standard urotherapy and specific urotherapy, pharmacologic therapy, anticholinergics and antimuscarinics, and also beta-3 agonists are used. In some cases, electrical nerve stimulation is used. If these three managements fail, we talk about refractory non-neurogenic overactive bladder. Botulinum toxin A is a possible treatment option in the management of refractory non-neurogenic overactive bladder. In 2011, FDA approved Botox injection to treat urinary incontinence in people with neurologic conditions such as spinal cord injury and multiple sclerosis who have overactivity of the bladder. In 2013, FDA approved the use of botulinum toxin A to treat overactive bladder in adults who can't use or do not respond to anticholinergics. And it took until 2021 before FDA approved botulinum toxin A for the treatment of detrusor overactivity associated with a neurologic condition in pediatric patients 5 years of age and older who have an inadequate response to or are intolerant of anticholinergic medication. In children with non-neurogenic overactive bladder, the treatment with botulinum toxin A is still off-label. Studies about the use of botulinum toxin A in children with non-neurogenic overactive bladder are scarce and often performed in small study groups. Many of them are also retrospective. The first point I want to focus on is how to use botulinum toxin A. What about the dose range? For onabotulinum toxin A, in the majority of studies, 50 to 100 units are used. Martadol used 12.5 units per kilogram without exceeding 200 units, and Lambrex used up to 300 units. In neurogenic detrusor overactivity, 200 units, not exceeding 6 units per kilogram, are commonly used. For abobotulinum toxin A, 375 to 500 units, or 8 units per kilogram, are used. Botulinum toxin A is diluted in an injectable saline solution. For onabotulinum toxin A, 100 units are diluted in 10 to 20 ml. For abobotulinum toxin A, 500 units in 20 to 25 ml. This dilution is injected at 15 to 20 points. And according to literature, there is no significant difference in effect for suburothelial and intradetrusor injections. The maximum effect is achieved between 2 and 6 weeks, and the effect lasts for 6 to 12 months. Repeat injections are often used, and according to literature, they are as effective as the first one, and they remain efficacious even for up to 11 injections. No changes of collagen deposit or fibrosis in the detrusor have been seen. According to dose impact, the results of all the studies are different from the more recent studies. In the study of ringworm, univariate analysis didn't show any significant association between dose per kilogram body weight and response rates on daytime incontinence and enuresis. Also, Blackburn didn't find any significant relation between dose and successful outcome. Ingham showed that there was no difference between the response rate of children treated with a low dose, 5 units per kilogram, and those treated with a high dose, 10 units per kilogram. On the contrary, Laecke, in his recent multinational, multi-center, randomized, double-blind, parallel group, multiple dose study, in which the patients received 25, 50, or 100 units, not exceeding 6 units per kilogram of onabotulinum toxin A, showed that there was a significant difference in treatment response, defined as a 50% or more improvement in urinary incontinence episodes, between the group receiving 100 units of onabotulinum toxin A and the group receiving 25 or 50 units of onabotulinum toxin A. The effect was significantly better in the group receiving 100 units. They also found that the change in volume per void from baseline was more than 10% in all treatment arms. This is substantial, but not statistically significant. They showed that treatment was well tolerated at all dose levels. There was no dose-dependent safety response, neither in those who got one treatment cycle nor in those who got repeated treatment cycles. Lambrechts performed a retrospective study in 50 patients. She found that in a group who received 100 to 150 units of botulinum toxin A, a 64.7% improvement of continence was seen. In the group who received 200 to 300 units of botulinum toxin A, 87.5% improvement of continence was found, which was statistically significant higher. When we look at the general outcome of the treatment with botulinum toxin A for refractory non-urogenic overactive bladder, the study by Byrak showed a significant decrease in voiding frequency, incontinence episodes, and an increase in bladder capacity in the patients treated with botulinum toxin A. Nearly 55% were completely dry on the 9th month of follow-up. 10 patients required repeat injections, 2 because of no improvement after the first injection, and 8 because of a relapse at the postoperative 9th month after initial significant improvement. In this study, they also found that there was a significant decrease in vasculourethral reflux after injection of botulinum toxin A, and that there was no significant impact on enuresis. The study of Ukher showed 6 months after injection a complete response of 32.2%, a partial response of 48.4%, and no response in 90.4%. Patients with a partial or no response got a second injection. A complete response rate in this group was found in 42.9%, a partial response in 42.9%, and no response in 14.3%. In total, after 12 months follow-up, 61.3% had a complete response. In her study, Lambrechts found a significant increase in functional bladder volume from a median of 52.9 to 70%. According to continence, on the short term, a complete response rate of 80% and a partial response rate of 54% was found. On the long term, the complete response rate increased to 26% and the partial response rate decreased to 20%. An important result of this study was that the long-term response was significantly higher in boys than in girls, and that small baseline functional bladder volume was a clear predictor for a favorable outcome. In his study, Laecke showed that the proportion of patients with a 50% or more reduction from baseline in daily frequency of daytime urinary incontinence episodes at 12 weeks was significantly higher in the group who received 100 units of onabotulinum toxin A than in those who received 25 units or 50 units. He also showed that for all treatment cycles, there was a continued improvement of urinary incontinence episodes. In the study of Ingham, complete response was found in 28%, partial response in 18%, and no response in 54%. The mean duration of the response was 7.9 months. An important finding was the higher response rate in boys than in girls, which was statistically significant. He also found a significant increase in total bladder capacity and rise in post-void residual in the group treated with botulinum toxin A, but no significant improvement of functional bladder capacity. When he compared the group with a low dose botulinum toxin A injection and a high dose botulinum toxin A, he found that there was a significant difference in increase of the total bladder capacity in favor of the high dose. No significant difference was seen for post-void residual and functional bladder capacity. In her retrospective study, in which 257 patients were included, Rengwar showed that the injection of botulinum toxin A had a better effect on daytime incontinence than on enuresis. The study also showed that there was a significant increase in bladder capacity after the first injection with botulinum toxin A, but also after the second and the third. Post-void residual was seen in 18.3% of the patients, with a median value of 40 ml. An important remark for this study is that a lot of patients got a combination with anticholinergics. In the group of the first injection, 47.7% were on anticholinergics. In the group who received the second injection, even more than 60% were on anticholinergics. In his study, Aladwan not only focused on the clinical outcome, but also on the urodynamic impact of botulinum toxin A injection in the detrusor. According to the clinical outcome, he found a significant change in urinary incontinence episodes per week, nocturnal enuresis, frequency, and quality of life. According to urodynamic parameters, studied 3 months post-injection, he found a significant improvement of systometric bladder capacity, maximum detrusor pressure, and mean compliance. 78% of the patients showed pre-treatment uninhibited detrusor contractions. In 67% of them, complete resolution was seen after treatment. According to literature, the side effects of botulinum toxin A in the treatment of refractory, non-erogenic overactive bladder are well acceptable. Urinary retention is reported between 0.4 and 4.7%. Urinary infection has been seen between 5.7 and 10.9%, and hematuria was found between 2 and 29%. Hubig and Rengwar showed that 1.2% of the patients develop vascular-urethral reflux after injection of botulinum toxin A in the detrusor. Other side effects mentioned in literature are non-specific pain, abdominal and penile pain, difficulty in initiating micturition, nasopharyngitis, and systemic side effects like listlessness, shortness of breath, and behavioral changes. Most of them are rather rare. In conclusion, we can say that the use of botulinum toxin A in refractory, non-erogenic overactive bladder is effective and safe.